de novo. Next slide, please. Next. Now the key thing is this diagram, and this you need to remember, and if you know this diagram, you would never have any problems. We have urothelium, which has mucosa, submucosa, and lamina propria. Next slide. So anything which is in the mucosa is your T1A, TA cancer. So TA, which has not gone into submucosa, this is submucosa, and anything which is into submucosa is T1. This is T1. T1 extends from mucosa up to the lamina propria. So this is lamina propria, and if we go beyond lamina propria, you have detrusor muscle, and this becomes your T2 cancer. Then you have some flat lesions which are called carcinoma in situ. Next slide, please. This is a very well-known diagram, the extension of tumor from the bladder to going to the muscles, and from muscles into the serosa, and from serosa into adjoining organs. We know that depending upon its T stage, the survival varies significantly. You have a very bad survival for high stage cancers, and very good survival in well-maintained patients who have TA or T1 lesion. And again, at that point, the most important determinant factor of survival is in a TA or T1 cancer. The grade, right? So if you have a TA low-grade cancer, it would be the same survival as somebody who does not have a bladder cancer. But if it is high grade, it's a bad disease. Even if it is TA high grade, it's as bad as T1 G3 or T1 high grade. Next slide, please. This is how it typically looks like, but sometimes it can be, next please, flat lesions which are difficult to diagnose, called the carcinoma in situ. If it is, it's visible clearly, or we lower down the lights? It's okay, okay. Next slide, please. TURBT, which is a cornerstone in the management of bladder cancer, is standardized procedure. And this standardization is maintained very clearly with good level of evidence in literature, and these are from the European Association last year's guidelines. It's important that you do examination under anesthesia, which is simply means that you put your finger in the rectum or vagina and try and see what's the stage of the. By this time, you have only done an ultrasound and nothing else. So you wish to know how bad the disease is. And this information can subsequently come to you after histopathology and CT scan. But if you know at this point that you're dealing with something which is not within the layers of the bladder and has gone beyond, then you would start preparation of this patient. Maybe one of the preparation would be to take biopsy from the paracollicular area in order to see if this patient can underwent orthotopic bladder. Next slide, please. Majority of your patients are going to have repeated cystoscopies. So those who have non-muscle invasive cancer will undergo cystoscopies for the next 10 years. And you would not remember where you have resected the previous tumor. So a small bladder diagram, if your hospital keeps record, that's wonderful, and we are very fortunate that these records are available of last time cystoscopy. If your hospital does not maintain records, then you should do it on your own. So maybe a piece of paper to the patient describing where the tumor was, or maybe some on your own record and where you have taken the biopsies from. So bladder diary is absolutely essential. Majority of tumor, if they recur, they will recur very close to from where you have resected these tumors previously. Next slide, please. Now, difficult situation number one. We have been taught that oncology and cancer management is by isolating the tumor from the surrounding normal tissue so that there is no spillage of tumor cells in the surrounding area and we have a clear situation. But this is something that we don't do. We don't do it for our TURBTs. ओके, इसमें आपको क्लिक करना होगा स्लाइड पे, इससे नहीं होगा ना. Okay, so this is typical TURBT that you do every day, and this is exactly what you should not be doing. Why, Hafiz? This is how you do TURBT, and this is not how you should be doing it. Why? Babar, right?
If it's a small lesion, then one should be removed
as one piece. Yeah. So this is all of you. This is the way you do it. Yeah. Okay. Now this is what you're doing. Who is this? Tiger Wood. So obviously it's a very good hit. You all guys are Tiger Wood. You are Tiger Wood when you are holding a resectoscope. But what we are doing wrong is this: we are spilling all that turf all around, and these are tumor cells, and they can get incorporated at any point in the bladder where there is a denuded mucosa. And there would be a lot of places where there would be denuded mucosa: prostatic fossa, urethra, areas of bladder where you've taken a random biopsy. And that's why about 10-15 years back, single installation of mitomycin C was introduced. So something that you instill into the bladder immediately after surgery, preferably within the first 6 hours. And there was a big meta-analysis by Sylvester, which showed that you would decrease the chances of early recurrence significantly. And you all know that if you have perforation or bleeding, you cannot stop irrigation, you can't put mitomycin. So these are some of the conditions that you would avoid. As you said, that if it's a small tumor, you can use your resectoscope and cut it en bloc, one piece, right? Or if it's a very small, tiny little one, you can just pluck it with your forceps, cold forceps, and bugby that area or do cystofulgration. Now this is another way of doing a, sorry. And there have been increasing talk about, Okay, thanks. So this is another recent way I've described about doing a TURBT. Now I'm using a Collins knife, and this Collins knife is first of all marking the boundaries of this relatively small tumor. We have started, and this is the laryngeal mask. So whenever you say that the patient is going to go home same day, they would not intubate that patient and give laryngeal mask. And you start seeing the anatomy of the bladder. You start seeing the muscles, which pathologists don't see. So you send them, and you have seen it yourself, but pathologists say that no muscle tissue available. So the first step is that you mark the periphery of the tumor, and once you have marked the periphery of the tumor, then you start dissecting it further. So I'm just going to expedite this a little bit. So once you have marked the periphery, the lady keeps coming back. This may be a dilemma, this may be a good thing. So now the principle of this surgery has actually come from the experience of which surgical procedure introduced in the last 12-15 years? This is the same principle that we will demonstrate in the second half of the procedure. Yeah, so when we do TURBT or TURP, this is what we are known. This is what we move actively, right? Now, passive movement is something that we have learned from our experience in laser surgeries. Because in laser surgery, you go to the core and lift the adenoma or tumor up. So once you have done that, you go all around, and then you try to lift this tumor from the base and remove it completely. थोड़ा सा इसको आगे बढ़ा दें. अरे यार तुम तो मुझसे भी ज्यादा होशियार निकले. और आगे यहाँ तक ले आइए. Okay. Okay. Anyhow, leave it. So it's very simple. You go into the base, you keep cutting it, you lift the tumor up, and this is what I wanted to show. You lift the tumor up, and once you start lifting it up, you can see the base of the tumor. You keep fulgurating that base, and the whole tumor comes out in one piece. Now, if it's a small tumor, you can actually elec it out in one piece. ठीक है, रहने दीजिए. And this is an elegant surgical procedure with a little base of the turf where tumor has been removed. So you can elec out the whole thing in one piece, and this is the tumor floating in your evacuator. And this is how it looks like. So it's one piece. But there is an advantage that potentially we have not spilled any tumors. The second difficult situation is carcinoma in situ. And carcinoma in situ is a real problem. This is a cystoscopy picture. I've shown it many times. So you don't see anything abnormal in this picture, right? And you see the blue light cystoscopy, and you can see there is tumor here, just underneath the ureteric orifice. And this is on blue light cystoscopy. Same here. Tumor which was not visible on white light is visible here on the blue light cystoscopy. Okay, turn it on, video. वीडियो पे कर्सर आप करें वो, हाँ, तो इसको फास्ट फॉरवर्ड हो सकती है. This is now the tumor which has been resected in various areas, and when you do a blue light cystoscopy, you will start seeing new areas of tumor, and most of these areas are actually very close to the tumor that you have resected. So this patient had a big tumor in various areas, something like this, which was not visible clearly on a white light, but it is visible now, even a papillary growth, not just carcinoma in situ. That papillary growth is visible on your blue light cystoscopies. So this is a potential advantage of this modality, and carcinoma in situ, when it is itself is a pretty deadly condition, can be picked up early with this. We know it can be done with either hexaminolevolinic acid or a pentaminolevolinic acid, increases sensitivity, but not really specificity to that extent, because there are so many conditions which can mimic carcinoma in situ on blue light cystoscopies, and they may not be tumors. There are various types of carcinoma in situ: primary, secondary, concurrent, or recurrent, and these are all very familiar definitions of these things. Intravesical BCG is the standard of treatment, and there is good quality evidence available, and very vigilant cystoscopies and postoperative care is required. If the BCG fails, you should go ahead and do a cystectomy earlier than later, because this is a deadly condition. It can metastasize. The question about random biopsies: do all of you take random biopsies during your TURBTs? No. What is the disadvantage of taking a random biopsy? You are potentially exposing epithelium, which can get incorporated with the tumor cells floating around in the bladder, right? So random biopsies, there are clear recommendations of when they should be taken, and you should always take a random biopsies if you have a cytology positive. Do all of you do cytologies before your flexible, before your check cystoscopies? Now this is a mandatory thing. Cytology before cystoscopy is mandatory, and you should always do it, because it can actually be an additional advantage. You would not pick up low-grade cancers, and you'd miss if you do a cytology and you find that the cytology is positive and you don't see anything, you probably have either an upper track. If you have an upper track abnormality, or if there is a situation in which there is carcinoma in situ. Situation number 4, which is doing second TUR. All of you know when second TUR should be done? Rehan?
When muscle fibers aren't seen for
So you have a pathology report saying that a high-grade tumor invading lamina propria, no muscle seen. What is the stage? TX. Good. So it's TX, meaning not staged. So then you will do a redo, which should be done ideally in 2 to 6 weeks time, and you take muscle and try and make sure that you're not dealing with the muscle invasive cancer. What about tumors which are close to the ureteric orifice? What do you do in a situation like this? You leave it, you resect it boldly, or ask somebody to come and do it, or schedule a patient when you are not around so that the blame doesn't come on you if there is an obstruction of the kidney. So that's a difficult situation. Now, if you resect the ureteric orifice and you do it with a cutting current, there would not be a significant harm. So you can do it and it would be all right in few days' time. But you need to do a functional study to make sure that there is no significant long-term obstruction. Now what I do is that, start the video. Now this patient had a tumor very close to the ureteric orifice and it is about to come. It is here. So that's a ureteral orifice. It's very close, and when you're cutting this tumor, you're actually cutting on the intramural part of the ureter. The rest of the procedure is same. You're marking all around and then you're going into the base and you start lifting and you start cutting those fibers. This is just like dissecting a tumor as you would do for an open surgical or a robotic surgical procedures. And you use this as your retractor to push the tumor and cut it whenever it's necessary. See how deep we have gone? We are actually clearly seeing the muscle fibers, and this whole tumor is, now this is the ureteric orifice. Can you see that? So you've done it very, very close, and you have actually shaved over the intramural ureter. But it's safe if you use cutting current. What about tumor in the diverticulum? That's a difficult situation, right? So this is a patient, and you can all see this IVU, X-ray, diverticulum. This is not my patient. This is a diverticulum on the left lateral wall. This somehow is not working. This is a CT scan. You can see that diverticulum with tumor inside. This is a diverticulum and not the ureter. And this is how it looked like. So what will you do in a situation? Now the problem with diverticulum is that if you resect deep, and that's what you should do to remove the whole tumor, you will perforate. And if you resect superficially, you will leave the tumor behind and you would not be able to stage the disease. You don't really need to. Do you need to stage disease as muscle invasive in a diverticulum? No, you don't, because there is no muscle. Right? It's only a mucosal outpouching, all the secondary or non-congenital acquired diverticulum. Video chalayega. Now the first thing that you need to do in a diverticulum, this is a diverticulum, small mouth, a small opening. You look around to make sure that there is no other disease. The first thing that I do is to open this diverticulum up. So you resect the margin of the diverticulum so that your narrow neck diverticulum becomes a wide neck diverticulum. And once you have a wide neck diverticulum, then you would resect this. The advantage is that once you have a wide neck diverticulum, you can actually instill your intravesical chemo or immunotherapy, and that would definitely come in contact with this diverticulum, and empty as well. Okay. Situation number 6, which is how to stratify disease. Not all muscle invasive cancers are the same. There are some which are bad cancer, some are good, and you need to stratify them. These are the points that you all know are used for stratification. Sorry, this is the point that the pathologist should report in your specimen. The grading system. Low risk tumors are primary, solitary, TA, low grade, less than 3 centimeters, no carcinoma in situ. High grade, NET, high grade, CIS, multiple tumors greater than 3 centimeters, intermediate in between these two. Okay, so and this can be easily done, and these are the two different systems. Kyoto has an additional thing of gender as well. EORTC does not have. This is the app that all of you should have in your phones, in your mobile phones, iPhones. So you can freely download this app. Once you have a patient in the lab, in the clinic, once with the pathology report, you need to just tap these buttons, whether it's a primary tumor, there was 1 tumor, 2 to 7 tumors, or 8 or more tumors. Is it TA or T1? Is it less than or greater than 3 centimeters? Is there concomitant CIS? And what is the grading system? How was the grade? So all this information is always available with the histopathology report. And once you have tapped these buttons, it will tell you what are the probability of recurrence and what is the probability of progression in this patient in terms of percentage. You can counsel your patient and then devise treatment methodology according to that. Long-term follow-up is again dependent upon what kind of disease you have. Low risk, intermediate risk, and high risk follow-up is different. They're not managed the same. I'm just running out short of time, so I'm going to rush a little bit. Obturator reflex. Who has not seen an obturator reflex during TURBT? All of you have. It's a problem, right? So what do you do? What do you do? Doc? Obturator reflex पता क्या होती है? आपसे पूछ रहा हूँ. जी जी.
It's your reflex action by the obturator nerve as the diathermy current goes to.
So what happens?
There is a
So the patient kicks you, right? Adductor या abductors? कौन से activate होते हैं? Adductor. So adductor में क्या होगा? Towards. Okay. So what do you do? If you have a large lateral wall tumor, what can you do?
under GA.
Under GA, that takes care of the obturator reflex.
I just completely paralyze the patient. I can block the obturator nerve.
How do you block the obturator nerve? Oh, just anesthesia. So I'll just show you how to block the obturator nerve. You can also do it if your anesthetist is not. Run the video, please. So these are the anatomical markings.
TURBT is ordinarily conducted under lumbar spinal anesthesia. An obturator nerve block is also used in order to prevent the obturator nerve reflex. For the obturator nerve block, we mark the pubic tubercle on the side of the block. The needle is inserted 2 centimeters lateral and 2 centimeters inferior to that point. Here's the obturator nerve block process. A pull needle connected to an electrostimulator is inserted perpendicularly. After the needle encounters the inferior pubic ramus, it is withdrawn slightly to subcutaneous depth and is then advanced slightly lateral and superior through the obturator canal to induce the obturator nerve response. After confirming that the response has been induced, a local anesthetic is injected.
See, now the nerve stimulation is going on, but there is no movement. So the obturator nerve is completely blocked, and you can go ahead and do. If you have tumors on both sides, on the both lateral walls, you can do it bilaterally. Okay, your anesthetist does it good. Otherwise, you can do it yourself. The only problem is that you would not be able to. This is one of the studies in which, with the use of obturator block, you decreases the chances of various jerks, problems during resection significantly. Now, what if you doing a check cystoscopy under local anesthetic and you find a small recurrence? What would you do? A very tiny, small little TA type of recurrence. The simplest thing, if you're doing a flexible cystoscopy, You don't really need to take a biopsy. You don't need to reschedule your patient under general anesthetic. You can go ahead, use a Bugby and चला दें इसको? नहीं चल रही, चले कोई बात नहीं. Use your Bugby on your flexible cystoscope and burn that area. You don't really need to do anything, and schedule him for another three months. If it is at 6 weeks, 6 months, or 1 year, schedule him back for 3 months. Okay, I'll stop here if there are any questions. Otherwise, we can go ahead for the second presentation.
So in case of the diverticular disease, which you explained in the first 6 days, because the tumor is a larger one, and we are not able to have the correct biopsy because it's very difficult to know all the things, then can we go further directly diverticulectomy, I think?
Yeah, I mean, laparoscopic or open diverticulectomy is an option. Generally, it should be avoided as much as possible, because the whole idea is that it is like taking an open biopsy, right? You need to make sure that there is no disease elsewhere in the bladder. So be very careful, maybe take a few random biopsies that's indicated in this situation, and make sure there is no other disease. If there is none, then you can go ahead and do a laparoscopic or open diverticulectomy.
If you're dealing with a growth in ureteric orifice, is there any added advantage of passing a ureteric stent before resection?
Unless you don't see it. Otherwise, you want to see it while you're resecting it. If you have seen it while you're resecting it, then obviously there is no advantage. Then you have to pass a double J stent, right? So, I mean, if you feel comfortable, and most gynecologists will feel comfortable with the ureteric stents. So I just know where the ureter is.
If the intramural part, you can go through it, see through it after resection, should we pass a DJ stent?
Well, if you are uncomfortable and you think that this ureter is either with the effect of diathermy or direct injury to the ureter, intramural ureter, or ureteric orifice itself, then yes. But normal situation, and you would not probably need to.
But is there always some fear to putting any stent or the...
Well, the idea is that your intravesical urine, which is going to reflux into the kidneys, potentially contains, yeah, but that has never been proven scientifically. There is a question from...
There is a question from Institute of Fitting Research.
Yes.
Dr. Ibrahim Ahmad asked a question. He said that can we use holmium laser for bladder tumor resection instead of using Collins knife?
Yeah, absolutely. The Collins knife is something that I feel comfortable, but holmium laser, and you use 550 micron fiber, and you can resect. Even you can use 365 microns at 40 watts. You can resect the whole thing just like we have done it with the Collins knife. So yes, you can do it. It's the safety is your ability to hold and maintain the fiber in place. So if there are no more questions, may I request Dr. Nazim to please come and talk about the principles of TURBT, and then we can take you through to the practical step with Dr. Nazim, myself, and Dr. Razi.
Thank you, Dr. Ahmad. So I think most of the points which I am presenting in my slides have been covered by Dr. Ahmad. So he was discussing difficult cases, but during the discussion of difficult cases, he has covered the one of the, important aspects, that is the principles of surgery. Right, so already mentioned by Dr. Ahmad that the bladder tumor is the second most common tumor of genitourinary tract. By the way, which one is the first? Prostate. Okay, so 90% of bladder tumor are urothelial carcinomas, and out of which more than 2/3 are, in fact 3/4 are non-muscle invasive bladder tumor, that is TA, TIS, and T1. Well explained by Dr. Ahmad previously. The transurethral resection of bladder tumor, which is TURBT, is the initial key step and the current standard, gold standard, for the initial diagnosis of all kind of bladder cancers, both muscle invasive, non-muscle invasive, and the other variants. And it is curative in the non-muscle invasive bladder tumors. Bladder cancer, for the bladder cancer, the proper diagnosis and efficient treatment is still challenging because this is a disease which has significant impact on patient's life. There are higher chances of recurrence and progression of the disease. So because of this high recurrence rate, the quality of TURBT, a good quality TURBT, not only allows the pathologist to accurately evaluate the histopathological status, but it also impacts the risk of recurrence and patient outcome. So as we all know that EORTC risk calculators have 6 things: the primary versus recurrent tumor, T stage, grade, number of lesions, size, and carcinoma in situ. And the lower 3 ones, the number of lesions, size, and carcinoma in situ, these are the 3 things which you can have evaluated on cystoscopy. So visual detection and resection is central to the optimal diagnosis and treatment. What are the problems with non-muscle invasive bladder cancer? The high risk, high grade, non-invasive tumors have significant risk of residual disease. And it has been shown that up to 50% of bladder tumor can have residual disease, and out of which 15% can be upstage subsequently. And 6 to 10% show a progression from a TA to T1 or a low grade to higher grade tumor in the later part with eventual lethal outcome. Carcinoma in situ also has got very high recurrence rate, up to 50% on first cystoscopy. So the goal of TURBT is the eradication of all visible tumor, to obtain adequate tissue specimens so that the tumor can be pathologically evaluated, its histology, its grading and staging can be identified and documented, and obviously what's the T stage and grade. So we all know that you do a TURBT for any suspicious lesion in the bladder, or you do a biopsy. The contraindications are so untreated UTI or uncorrected coagulopathy, and obviously these are the absolute contraindications. The relative contraindications are patient related, if patient has significant cardiopulmonary conditions or the other conditions which put him at higher risk for the anesthesia and perioperative during the perioperative period. These are the relative contraindications. So how would you preoperatively prepare a patient for TURBT?
First of all, the preoperative anesthesia
right. So patient you will send the patient for risk stratification. So preoperatively the patient is okay. What else? Right. So you will do a urine culture and you will treat UTI if it is culture proven. If the patient is taking Ascard, so you should stop at 5 to 7 days. If he's taking clopidogrel, 7 to 10 days, right? What else? So you will counsel the patient and you will do informed consent. And I mean, what about antibiotics?
You don't need just 1 shot before surgery.
So again, this is controversial, but the guidelines generally say that for a small tumor, only 1 single shot prophylactic antibiotic is sufficient. If the tumor is large or there is a lot of necrotic component, then you need 3 doses of antibiotic. Anesthesia, general anesthesia with complete relaxation and paralysis, or it can be done under spinal anesthesia, but be prepared for the obturator jerk. What are the instruments that you need for a TURBT? So obviously you would need a telescope. If you have the option of buying only 1 telescope, which one would you buy? 30 degree or 0 degree? 30 degree. So a scope, then there is working element for TURBT, which comprises of resectoscope. This is the endovision sheath. In the resectoscope, you have an outer sheath, the inner sheath. Through the outer sheath, irrigation goes on, and through the inner sheath, there is suction. And then there are different kind of loops. So there are different kinds of resection devices. There are loops. There are the ball electrode. And then there are Collins knife, and then there are straight loops. Besides that, you would need evacuator to evacuate the tumor chips. You would definitely need a light source. You would need a camera. You would need a monitor and an irrigation fluid. What else? depending upon whether you have monopolar TUR, monopolar electrocautery or the bipolar electrocautery, you would need the
line or the glycine.
Glycine or and the energy source. So positioning. This is the appropriate positioning of a patient for TURBT. The thighs should be bent and at an angle of 90 degrees because it will allow the surgeon a maneuverability. The buttocks should be kept at the edge of the table. Otherwise, again, it will difficult your maneuverability difficult. This is how the operating room setup looks like. You would have a tower. You would have the irrigation fluid on the left side. The monitor is generally at the level of the operating surgeon's head. The operating surgeon sits in between the patient's thighs. The whole area is prepped and draped, and only the penis is exposed. So coming to the principles according to 2017's EAU guidelines mentioned by Dr. Ahmad as well, that TURBT followed by pathological investigation is essential step in treatment of non-muscle invasive bladder tumor. The recommendations is that the TURBT should be performed systematically. First of all, a bimanual palpation should be done under general anesthesia. Then you, under vision, you insert a resectoscope. You inspect the whole urethra, the prostatic urethra, whole of the urothelial lining of bladder. If there is no gross lesion and the cytology is positive, you would take random biopsies or cold cup biopsies as well as biopsies from the prostatic urethra. For the tumor, you would resect it. You can resect it piecemeal or you can resect it en bloc. And it is important that you record the findings of TURBT by virtue of bladder diagram. So this is bladder diagram, and this should be a uniform diagram with all these points. 1 should be the trigone, 2 should be the right ureteric orifice, and so on and so forth. And en bloc resection or a resection in piecemeal for the exophytic part of tumor is recommended. Cauterization should be avoided as much as you can, because the more you coagulate or more you cauterize, it will make the specimen difficult for the histopathologist to evaluate. And as mentioned previously, if there is no obvious lesion, then you should take random biopsies from the prostatic urethra as well as from the bladder. Second look or second TURBT or relook TURBT should be done after 2 to 6 weeks if there is no muscle tissue in the first biopsy, if this is a T1 lesion, or if you know that you have incompletely resected the tumor. Right. So the surgical technique of TURBT. So again, as I mentioned, that the bladder should be evaluated systematically. And the typical resection is in the antegrade direction, in which you move your resecting loop forward to backwards towards the resectoscope. So the loop of resectoscope is placed behind the tumor, and then it is gently retracted towards the resectoscope. This is the schematic diagram. You see a papillary growth here. You take your loop behind it, and then you resect it from the luminal surface towards the urothelium. And it shows that you resect it in piecemeal from the lumen side downwards, and then you take a biopsy from the tumor base as well. The smaller pedicle tumors can be resected en bloc. You can use the monopolar diathermy with the help of the Collins knife. You can use laser, as the question was asked from the IKD. But generally, the en bloc resection is not suitable if the tumor is larger, more than 2.5 centimeter, or if the tumor is located at the bladder dome or on the anterior wall. So here you can see an exophytic papillary tumor, and this is the real life picture, how you pass your loop ahead of it and then resect it. This is your advancement of loop through the tumor, and this is how you do you resect the first strip. Retrograde TURBT, it is generally not recommended to do a retrograde TURBT or advance your loop ahead of you, because it carries the high risk of bladder wall perforation. But again, as mentioned in the previous presentation, if you are resecting the tumor en bloc for the small papillary lesion, you can adopt this strategy. The loop is placed above the level of urothelium in front of its pedicle. The pedicle is transected by gentle retrograde resection of the loop, and then it is carried out. So again, this is the schematic diagram. You keep the loop above the surface of urothelium at the level of pedicle. You sweep it away, but subsequent biopsy through the tumor base is taken in the antegrade fashion. The next step, once you have removed the visible tumor, is the resection of tumor base. So the additional samples are taken from the base of resection, including the detrusor muscle. So should the tumor which is taken from the tumor base be sent with the rest of the tumor? It should be labeled and sent separately. So this is how you resect the tumor base. And then the final step is resection from the tumor margin. So it is the TURBT is completed by additional resection of normal looking urothelium from the lateral margins of the resection. That's how you resect the tumor margins. And this is the diagram in which you are seeing a real life picture how you remove the edges from the tumor, or how you take a deep cold cup biopsy from the tumor base. Now for the broad-based tumors, which are non-papillary, TURBT starts at the tip, that is tip of the iceberg, and then you gradually extend it downward. So this is a broad-based solid tumor. That's how you resect it. And as already mentioned previously, that a tumor which is in the difficult situation in the bladder diverticulum, it's a special tumor entity because it's a true diverticulum. There is no detrusor muscle. And if you resect it, you are generally passing your loop through the perivesical fat. Therefore, the risk of perforation is very high. Any infiltrative growth through the lamina propria may be equal to T3 stage and might require aggressive treatment, including the cystectomy. For the lateral wall tumors, if you know beforehand that the tumor is on the right or the left lateral wall, it is better to have a pharmacological blockade of obturator nerve before TURBT and to place the patient under general anesthesia with muscle relaxant and complete paralysis. Right? Again, because of the obturator jerk. Again, one of the question is whether one should proceed with monopolar TURBT or bipolar TURBT. Which one is better? Why?
Because the chance of obturator reflex is less.
1, 2.
And if there is you don't worry about the fluid.
Again, the irrigation fluid is generally normal saline, so the chances of TUR syndrome or the fluid overload, the chances of fluid overload are always there, but the TUR syndrome is less. And there is less charring or less artifact on the resected specimen. So reduced risk of complication.
Benefit of using RO water for seedlings.
RO water?
The normal
distilled water. Distilled water, but generally distilled water is not preferred because it has no tonicity. So you use an isotonic solution which is electrolyte depleted for the conventional monopolar TUR, either TURP or TURBT. Right, so what should be the post-operative care? You have resected a tumor, Salman. How would you take care of that patient post-resection? Catheter. So what size catheter would you prefer? Okay, good. So large lumen, 2-way or 3-way? 3-way catheter. So for how long you would continue irrigation?
Always 2 to 12 to 3 days.
Right.
Meanwhile, if they don't change, also they will seek up.
Right. So what are the potential complications? Obviously, bleeding, perforation. So perforation can be extraperitoneal if you have resected a tumor from the bladder base. If you have resected it from the anterior wall or from the dome, then it can be intraperitoneal perforation. So how would you manage an intraperitoneal perforation?
Open.
So can you manage it with catheter only? No. So an intraperitoneal perforation requires laparotomy, bladder repair, placement of a peritoneal drain, and double drainage of bladder with the suprapubic and perurethral catheter. And again, bladder perforation can be provoked with the obturator jerk, and in order to prevent it, you should reduce the power, cutting power up to 70 watts. And again, damage to the ureteric orifice. So ureteric orifices can be resected if there is tumor involvement at the ureteric orifices. The damage can be minimized if you use pure cut. And if you suspect any injury to the ureteric orifice and subsequent stenosis or vesico-ureteric reflux, then a double J stent can be placed in case of any doubt. So this is last slide. Following the resection, it is a principle and it is an established practice to give single instillation of chemotherapeutic agent. And the meta-analysis by Sylvester has shown that it decreases the recurrence rate by 39%. Single installation of chemotherapeutic agent should be given preferably within first 6 hours. And what are the contraindications for single installation of chemotherapeutic agent? If there is ongoing hematuria or if you suspect there is perforation because of systemic absorption. The most common agent used worldwide for SICA is mitomycin C. However, you can use thiotepa, you can use apirubicin, doxorubicin, etc. Thank you very much. So, any queries regarding the principles, basic principles? It was I think, a very basic presentation, mainly for the audience who are younger and who are starting doing the TURBTs. So any queries, any questions?
There is a query from North region. He asked how to proceed to perforate bladder diverticulum while resecting diverticulum tumor.
So if you have perforated the diverticulum, which means that you have perforated the bladder. So in that case, again, it depends upon the location. If it's a paraureteric diverticulum, obviously perforation of a diverticular tumor means that you have upstaged the disease. The tumor has spread outside the bladder. But again, if you are suspecting an extraperitoneal perforation, the location of diverticulum is at the bladder base. If it is a paraureteral diverticulum, then you can manage it by simply placing a catheter for 7 to 10 days, and then you can do a cystogram and then take the catheter out. If the location of diverticulum, however, is near the dome or not near the base, then obviously the patient would require laparotomy and repair. So if there are no more questions, I would request Dr. Raziuddin to move on for the next session.
We have opportunity to practice the procedure. Maybe we can have some mid-level residents. How many of you are second or third year? Maybe you take
So we have how much? We have 35 minutes, and this usually takes about 5 to 7 minutes. So we'll try to accommodate as many as possible. Ajo. पहले एक demonstrate करें. ये अभी हम एक simple वाला लगाते हैं. TURP नहीं, TURBT, bladder tumor. Bladder tumor वाला कितना? हाँ ये TURBT. इसमें से शुरू करेंगे. कीबोर्ड तो नहीं चाहिए ना? नहीं, वो सकता है. अच्छा. So what it does is you have to first go in. So who's coming? Who's the first person? आप आ रही? Are you the first person? क्या नाम है आपका? Marvi. So what it will score you. You have to go in, see, inspect like you normally do. You look at the orifices. You look at all the bladder. So आ जाओ.
I think the one who is performing here can sit because we have projected it already on the monitor.
Rest can sit and then we'll try to.
And we can have interactive discussion in between as well. Right? She is on the hot seat.
हाँ ठीक है. बता दी हाँ. चलो. Why is the color of the paddle different for cutting and coagulation, and why is the sound different? Marvi?
Sir, we use yellow for cutting and fog for blue for coagulation.
Why is it like that? चलो शुरू कर दो क्योंकि time. And why is the sound different? It's no. In your theater also it's the same, right? The idea of simulator is to so you keep this closed whenever you're inspecting. At the moment you're inspecting, right? So look at the ureteric orifices. Find the ureteric orifices, both of them, and look at the tumor all around.
Come back to the bladder neck. Do a systematic.
कैसे आप how do you find what is the method?
We just go inside and see posterior wall first.
हाँ.
Right.
सबसे पहले ट्राइगोन नजर आता है ना?
But sir, we do it from the posterior wall.
ठीक है, कर लो. ट्राइगोन पहले देखो, posterior wall देखो. Yeah. So the question is how to find the ureteric orifices.
This is the ureteric.
ठीक है. उसका कोई मेथड है या बस नजर आ जाता है?
सर वो नेक्स्ट जैसे we are go down.
Yeah. Yes. So you go in the neck. Yes, and you look at the trigon. Trigon के color different होता है, right? It's more vascular usually. Then you look at the interureteric bar, which lies in between the two ureteric orifices. Yeah. Sometimes if the bladder is very tuberculated, you have difficulty finding it. So you must find the interureteric bar first.
From the neck.
Yes. You have to do it systematically. ठीक है, ये नहीं है कि एक इधर राइट लेटर देख लिया फिर लेफ्ट लेटर देख लिया और यही इसकी जो जज करेगा उसमें आपको कम स्कोर करेगा अगर आप हैपहैज़र्डली कर रहे हैं तो. ठीक है, I think time to start. So everyone knows how the 30-degree scope looks like. How does it look like? It looks down. ठीक है. So when you're looking at the right lateral wall, you turn it like that. When you're looking at the left lateral wall, you look at that. Then ऊपर देखने के लिए आप बिल्कुल उसको उल्टा करते हैं और फिर you push the bladder, right? So this is a larger tumor. It's more than 2.5 centimeter. So the methods that were told previously, you will use that. You will cut that apex and then you go down with each cut. So you be careful, the bladder is full, it's not empty and it's not too distended, adequately distended, otherwise what can happen? If it's not distended, you may cut the wall behind it, right? You may cause a perforation. यहाँ पे ये टास्क का भी बताएगा कि ट्यूमर आपने कितनी बना दी है. ठीक है, सही बता रहा है. एक और भी है इसमें. Have you done this on a patient before? So how does it feel? Is it similar or very different?
No, it's different.
क्या different है?
Like in the real patient, it's more difficult.
वो तो है मतलब टेंशन नहीं है इसमें. टाइम हो गया है 5 minutes में 15 minutes है.
It's a very high fidelity simulator, and it mimics the almost, the real situation of a tumor.
How we believe in
देखो ब्लीडिंग की वजह से आपका विजन खराब हो रहा है. So I think you're almost done. हो गया 100%, 98% हो गया. एक छोटा सा clip. Good. हो गया 100% हो गया. So once done, you should take a biopsy, deep biopsy, and make sure there is some muscle and send it in a separate container. So that's important to send it in a separate container. ठीक है. Right. So she resected full tumor, both of them. आ जाओ. Safety visualization, bladder service.
So very good score.
Time, a very good score, yeah. Blood lost, not much blood lost. Safety is very good. ठीक है. आप कौन से लेवल के हैं?
R2.
हाँ? R2 है. थोड़ा सा डिफरेंट, थोड़ा सा डिफिकल्ट कर देते हैं. केस 3 कर देते हैं. केस 3, हाँ. चलें जी. So it's the same. You inspect first, have a look around, and then start. Say. So slightly larger tumors. There. How many tumors are there? बाहर आ गए. I think you're all set. दूसरा ये कैमरा हमेशा. So this is usually at the 6 o'clock position, right? आप अंदर चलो. बाहर आ गया. हाँ. ठीक है. You've had a good look. Any comments are welcome.
You have 3 tumors. Which one would you like to resect first?
Hello.
One near the dome, one near the base.
जी कौन बोल रहा है? जी मैं जरा थोड़ा बिजी हूँ. नहीं यार अभी नहीं. मैं अभी तो क्लिनिक में नहीं हूँ. Right. So this one is a slightly broad-based tumor, so you have to be very careful. So as a rule, if there is little bit of bleeding and it's not bothering you too much and it's not obscuring your view and you have to cut more, then you cut. You don't need to coagulate. But if you can't proceed any further without coagulating, then you coagulate first, right? Once you've started to cut, you should try and keep your hand stable, right? So, एक तो आप loop को move कर रहे हैं ना, तो एक आप अगर scope को भी move करेंगे, तो you have another dimension of movement. Try not to move that. That becomes very dangerous. Yeah. Do all of you use a camera while doing this? सबके सेंटर्स में होता है 100%. कोई कैमरे के बगैर करता है? मैं बोली.
So tumor which is located at the dome, what other maneuver would you like to do? Anterior wall or dome की junction पर
प्रेस करते हैं ऊपर से प्रेस करते हैं.
So bladder should be half filled, not
half filled.
And you can ask your assistant to apply a constant pressure. Don't keep on shaking his hand. It will be difficult for you to operate with one hand and then put the other hand on the supervision.
यहाँ पे अब you might want to find the bleeder first because it's pretty risky to proceed any further, right?
It's here, yeah, near there somewhere.
इसके पीछे छुपा हुआ है. So you have to hurry up. It's like one tumor you've done, the other tumor is 30%. थोड़ी देर के लिए valve close कर सकते हैं because it's giving you a hint to close the valve and then full खोल दो हाँ. ये floating है हाँ ये ऐसे में केस 2 बेहतर है नेक्स्ट केस 2 ही करेंगे क्योंकि जल्दी हो जाता है लंबा हो जाता है आप कौन से सेंटर से हैं लैक
just want to know if we can use laser instead of resection by monopolar or bipolar. Have you ever have experience with it?
Frustrate हो गए. So sometimes you get.
I do not know. I have made so much. But normally my computer we can talk by.
ये कहाँ से आ रहा है?
I think we have mics here, up here.
So yes, I think you finished it. Let's look at the quick. I mean, let's see. So you got all the thing. What about the safety? Let's see. Tool active without contact. So one mistake that is pointed out is that without touching the tumor, you had your foot on the cutting, right? So that's dangerous. So that even if by mistake you put your foot, you will not injure anything, right? कभी-कभी ऐसा होता है वो आपको temptation होती है उसके ऊपर एक if you have your foot on it, it's going to be very dangerous. So never put your foot when you're doing that, right? We've had residents making their marks inside the bladder. So चलो next कौन आना चाहता है? टाइम थोड़ा है. I don't know next sessions में. आप कौन से R2 है? कहाँ से हैं आप? लियाकत से. Okay. ठीक है. सेकंड वाला जो केस है ना वो अच्छा है. उसमें 2 हैं और हाँ. चलें जी. हाँ सेकंड इसमें 2 ट्यूमर्स हैं तो थोड़ा जल्दी हो जाता है. वो ज्यादा बड़े हैं. We can try and squeeze one more person ना. ठीक है. अब इसको अलाइन करके first you have to inspect, है ना? So जैसे करते हैं इसको अंदर रखो. जब आप सिस्टोस्कोपी करने की कोशिश करें उसको अंदर रखो. हाँ ये वो यू नजर आया है. दूसरा वो है. हाँ ठीक है. ब्लैडर की ऑल अराउंड देख लो. यस. So this camera has made learning very important, very easy, right? For us also who are teaching, ज़रा सा गड़बड़ होती है हम हाथ पकड़ सकते हैं, ठीक है, वरना एंग्जाइटी सिखाने वाले की एंग्जाइटी भी बहुत ज़्यादा होती है. तो लाइक वी हैव बीन ट्रेन्ड ऑन आइदर वो दिखा दिया, एक दफ़ा दिखा दिया, फिर अच्छा ये काटने लगे हम, या वी हैड दोज टीचिंग एड्स व्हिच वर हॉरिबल, इतने हैवी होते थे, एक इधर लगा देते थे और हम ऐसे माइक्रोस्कोप की तरफ पकड़ के देख रहे थे, जैसे ब्लीडिंग होती थी वो उतार देते थे हमारे जो टीचर्स होते थे. तो इसमें एक तो मैग्नीफाइड है, आप गलती करें तो पकड़ सकते हैं आपको, इससे टीचिंग बड़ी आसान हो गई है. चलो तुमने जो कर दिया है अब उसको करो, क्योंकि वो फिर आपको नंबर कम देगा. इसमें 3 ट्यूमर है. अच्छा ठीक. So what settings do we use when you're doing a TURBT? What coagulation settings, what cutting settings?
100.
Yeah, normally we start with 120 and 60 and then we reduce. वो जो operator kick की बात हुई थी, उसमें अगर ये हो रहा हो तो you can actually reduce the setting also, right? या अगर blend को आप adjust कर सकते हैं और आप settings भी कम कर सकते हैं. Always try to touch the bleeder with the apex and then हवाई फायर नहीं करने, उसमें टच करके और फिर करने हैं, राइट? सही, ये हो गया 100%. Right, these are smaller ones, जल्दी हो जाएंगे. Maybe you try to come from the other side, ऐसे घुमा लो इसको इस साइड से. सही, हाँ सही पे करना है, यहाँ से टच नजदीक जाना होगा, you're a bit far, yeah. तब अभी 28% हुआ है. What do you want to do next? Start कर दें या क्या? नमाज आ रहे हैं? अच्छा, कांटेक्ट कर लो, वरना we'll squeeze in one more. हाँ. ये वाला तो हो गया, और एक जो है ना तुम्हारा रह गया 28%, वो वाला आधा रह गया. हाँ, उसके नजदीक जाके वो डिफिकल्ट हो रहा है ना, डिफिकल्ट हो, थोड़ा आगे चले जाओ, खोलो उसको. हाँ, ये तो हो गया, ये हो गया सर, राइट साइड पे ये वाला है, ये वाला है. हाँ, इसके नजदीक जाके करो इसको. यू हैव टू गो इन फ्रंट. हाँ, ये है. या यस, आ गया 60% हो गया. स्टार्ट कर देते हैं सोने से. अच्छा, बस सही, ये फिनिश होता है तो ओके. लेट्स सी. ठीक है. So again, for 1 second you were without active, you were active without contact. Otherwise, visibility was good, no blood loss, very good. Procedure time was good. Goal was less than 600 seconds. Cumulative path length. So it was good, very good.
and which shows the various wavelengths of lights against the tissue and the absorption of the laser against the tissue. So the holmium laser is highly absorbed by water, and that's how it induces a clear cut through the tissues. And majority of it is absorbed superficially with minimal collateral damage. Now, holmium laser enucleation of prostate, or HOLEP, is the minimally invasive procedure for BPH, and we will discuss that it is independent of prostate size. There is no limitation of prostate size for HOLEP in contrast to TURP. The HOLEP uses an end-firing laser which cut grooves into the prostate down to the level of capsule. And we will discuss in the subsequent session what are the principles. The adenoma is separated from the capsule, similar to what we used to do in the open prostatectomy. The lobes are dissected off from the capsule, the prostate. These lobes are then pushed into the bladder and then are fragmented with the help of morcellator or with the help of a loop, just like you do a transurethral resection. However, HOLEP has a steep learning curve and it is difficult to master as compared to vaporization techniques. So this is a typical resectoscope for performing the HOLEP, which is generally a 24 to 26 French sheath. It has got a modified inner sheath, metal sheath, through which you pass a laser fiber, and it has also the property to stabilize the laser fiber. This is the light source, and that's the morcellator. That's the handle of it. And then the morcellator goes through the scope into the bladder where you resect the prostate lobes. So what are the technical principles of HOLEP? So first of all, you do a blunt dissection with the help of resectoscope. You use the resectoscope beak to continuously push the adenoma, and you at the same time dissect it with the help of the laser fiber. Holmium laser gives sharp incisions in the prostate, and at the same time, it not only vaporizes it, but it also coagulates it. Therefore, there is very minimal bleeding while performing the HOLEP. The plane is developed, it is identified between the adenoma and the surgical capsule, and it is very much similar to what used to be done in the open prostatectomy. And what's the principle is that once you release the laser pulse, it generates a steam bubble, and the steam bubble disrupts or it bursts very quickly in microseconds, which is generated in front of the laser fiber, and the energy which is liberated from the bubble, steam bubble, actually dissects the tissue off. The minimum power or intensity of holmium laser that is needed for the HOLEP is at least 80 watts. And the setting of 2 to 2.5 joules and 20 to 550 hertz is used, and the fiber diameter is 550 micron, and it is an end-firing holmium fiber. The tissue effect is rapid and hemostasis is excellent. Now coming to the literature evidence. So this is a generic slide which shows that there are many randomized controlled trials, there are many meta-analysis and systematic reviews, and it has shown that what is good about HOLEP? HOLEP has shorter hospital stay compared to TURP. It has shorter catheterization time, it has less blood loss, and you can have much more tissue resected as compared to TURP. What is bad about HOLEP? It has longer operation time, and it has much more steeper learning curve compared to TUR. And what is the same? It has the efficacy in terms of the IPSS, in terms of maximum flow, in terms of PVR, which is equivalent to TURP, and the sexual function remains the same with both the modalities. And in UK, it is the only laser technique which is approved by National Institute of Clinical Excellence. So the PVP, the thulium laser, etc., these are not approved over there. So this is a recently published study which was about which is a systematic review and meta-analysis. It included 15 studies and 8 randomized control, including 8 randomized controlled trials, and it showed a head-to-head comparison of HOLEP versus TURP, and nearly 850 patients were included. The efficacy indicators, they analyzed 3 indicators: the efficacy indicators, the safety indicators, and perioperative indicators. The efficacy indicators were not significantly different between the two in terms of quality of life, in terms of post-void residual volume, IPSS, and Qmax. So both were similar. In terms of safety, the HOLEP was much more safer because it showed less blood loss and less need for the blood transfusion. However, there was no significant difference in terms of early and the late post-operative complication in this meta-analysis. The perioperative indicators showed that HOLEP required much more longer time and a shorter catheterization time. This is another meta-analysis, a bit older one, and it showed that HOLEP was superior in the pooled estimate of studies as compared to TURP in terms of, again, shorter catheterization time, 17 to 31 hours, compared to 43 to 57 hours for TUR. Hospital stay was about 1 to 3 days for 1 to 2.5 days for HOLEP, as compared to 2 to about 3.5, 4 days for TURP. However, TURP was superior because it had less operative time, more or less the same result as compared to the previous meta-analysis. There are other trials and meta-analysis which have compared holmium laser enucleation versus open prostatectomy, and HOLEP was found to have a longer operative time compared to open prostatectomy, shorter catheterization time, shorter hospital stay, less perioperative blood transfusion, and there were no significant difference in terms of need for reoperation. History, the risk of the stricture and bladder neck contraction and incontinence, and the quality indicators in terms of efficacy, that is IPSS and Qmax, were similar in both the short-term as well as long-term follow-up. This is a famous randomized control trial which is I think cited 100 of times by Kuntz, and it was published in EAU, European Journal of European Urology, and it was a head-to-head trial, 1-to-1 randomization with HOLEP versus open prostatectomy, and they included larger prostates, those which were more than 100 grams. And the preoperative and postoperative assessments were done according to IPSS or AUA, the Qmax, post-wide residual volume, and these indices were measured at 1 month, 3 months, 6 months, and thereafter annually. This is the table which shows the baseline characteristics between the two groups, the HOLEP group as well as open prostatectomy. Both the groups were similar with regard to age, prostate volume, detrusor pressure, P-DAT Qmax, detrusor pressure at maximum flow, the Qmax, post-wide residual volume, and IPSS. And this is the table which shows the efficacy measures in terms of AUA score, the Qmax, and residual volume. And you can appreciate that preoperatively the IPSS was very high, 22 and 21 in both groups, and it dropped to 2.3, between 2 to 3 at the short term as well as on the long term. Similarly, the Qmax was very low. For the big prostate, it was 3.8 and 3.6, and it increased up to 27, 28, up to 30, and the effect was maintained in the long term up to 5 years. The residual volume were very high, up to 280, up to 300 in the pre-op period, and it dropped to negligible range both in the short terms and in the long terms. So HOLEP was as effective as open prostatectomy regarding improvement in micturition, and it seems to be a true endourological alternative to open prostatectomy. I've taken this table from the EAU guidelines, which has summarized the different RCTs and the results of HOLEP with regard to improvement in urodynamic parameters, symptom score, and PSA reduction. And you would see that these are the head-to-head trials between HOLEP and TURP, the mean prostate size, which were comparable in all of them. And you can see that there was near about 80 to 90% improvement in the change in the symptoms, and around 500 to 700% improvement in Qmax, and around 100% improvement in the post-wide residual volume. Similarly, these are the other trials comparing the TURP and HOLEP, and this one, which we just discussed, between HOLEP and open prostatectomy, and more or less the same results. Now, what does literature say about the complication with HOLEP? So this is a study which was again published in 2005. It's a bit older one, but it's a larger series of more than 1,800 patients. And it showed that HOLEP has a blood transfusion rate of only 1% with perioperative mortality of only 0.05%. The capsular perforation rate ranged between 0.3 to 10%, and it has comparable outcome as compared to TURP and open prostatectomy. No statistically significant difference was found between HOLEP and TURP with regard to urethral strictures. It was not significant, but it was higher in the TURP, 4.4% versus 2.6% in HOLEP group. With regard to stress incontinence, both have similar complication rate of 1.5%. The blood transfusion was virtually nil in HOLEP as compared to TUR, and the need for re-intervention was almost half in the HOLEP group as compared to TURP group. Now, what does literature say about HOLEP and prostate size? So, HOLEP outcome has been shown to be independent of prostate size and shape based upon the data from high quality RCTs. Therefore, American Urological Association guidelines have said that it is a surgical option for men with larger prostate, that is more than 100 grams, and EAU guideline recommended for any prostate which is more than 80 grams. So this is a study which was published in 2017, and it included 3 groups it included both the small, large and the giant prostates. It included around 459 patients divided into 3 groups. Group 1 was for the prostate less than 100 grams, group 2 for prostate between 100 to 200 grams, and group 3 for more than 200 grams. And these patients underwent HOLEP and they were followed up for 18 months. This is the intraoperative finding. As expected, the group 3 with the prostates of more than 200 grams, they have higher operative time in the terms of enucleation, morcellation, and higher weight of enucleated tissue, which was all statistically significant. Surprisingly, in the larger prostates, the enucleation efficacy and morcellation efficacy in terms of gram resected per minute was higher for the larger prostate as compared to the smaller prostate. For the postoperative indices, the catheterization time for the small and the giant prostate was similar, around 24 hours. The hospitalization was also more or less the same in terms of days. The postoperative bleeding was similar, but the urinary incontinence was much more prevalent, 16% compared to 7% between the small and giant prostates. And the functional outcomes were more or less similar in all 3 groups in terms of IPSS, quality of life, Qmax, and post-void residual volume. Now, what does literature say about the prostate morphology? Whether HOLEP is good for a bilobar prostatic enlargement or a trilobar prostatic enlargement. So Weizenbaugh et al., this is another recent study which was published in Urology, and they compared outcome of HOLEP in trilobar versus bilobar prostate. They included more than 300 patients, out of which 142 had bilobar prostate and 162 had trilobar prostate. The operative time was a bit shorter, 100 minutes for bilobar one as compared to 112 minutes for trilobar. And the post-operative outcome were similar in the 2 groups in terms of IPSS and the change in IPSS, Qmax and the change in Qmax, the quality of life or Bother score, post-void residue, and the complication rates. Now, HOLEP as retreatment. Can we use HOLEP as a retreatment for a prostate which has regrown after the initial surgery? So we all know that recurrent BPH or the prostate can regrow because of after a time span of like 8 to 10 years, or if the initial surgery is inadequate, then it can regrow, and the retreatment is required in about 3 to 8.6% of men after 5 years. So HOLEP has been found to be feasible as well as safe as a retreatment modality, and it has shown excellent outcomes for men who have previous BPH surgery. It is shown that surgical retreatment for BPH regrowth after TURP and photovaporization of prostate ranges between 5 to 17.7%, while for the HOLEP, the retreatment, the need for retreatment is only up to 1.4%. This is a study which is published in December 2017 in Journal of Urology by Marian et al. And it was a multi-center series, and they compared primary HOLEP, those who underwent primary HOLEP, about 1182 patients, versus those who had retreatment with HOLEP in 360 patients. And they found that there was no difference between the primary HOLEP versus retreatment in terms of Qmax and post-void residual volume. But the retreatment arm was actually found to have a shorter operative time, less blood loss, shorter day of stay, and less tissue resected. However, there was slightly higher rate of post-operative clot retention in the retreatment arm as compared to primary HOLEP. Now, what about urinary retention? So post-HOLEP, there are two studies, Johnson et al. And Peterson et al., and they showed that post-HOLEP, all patients were voiding spontaneously without any complications. The Johnson et al. Study was a comparative study, and they compared the outcome in those individuals who were voiding spontaneously prior to HOLEP compared to those who had actually urinary retention and were operated by HOLEP. And they found that the non-retention group had a lower blood transfusion rate and did not require long-term catheterization, but the functional outcomes were equal in both groups. What about sexual function? So the studies have shown that the rate of retrograde ejaculation is slightly less as compared to TUR, ranging from 70 to 80%. What about sexual function? So there are prospective studies which have compared holmium laser enucleation versus TURP, and the sexual outcomes are similar both in terms of type of sexual dysfunction as well as frequency. And those studies which have utilized the objective parameters like IIEF, International Index of Erectile Function, they have found that there was no influence of HOLEP in terms of overall sexual function with regard to erection and satisfaction of the patient as well as satisfaction of the partner. Kim et al. Have done a study, and they found that some patients after HOLEP actually showed improvement in IIEF parameters, and Elshal et al. Have found that more than 60% of patients reported improvement in sexual function. So HOLEP actually improves the sexual function as well. Now, what about anticoagulation? So can we do HOLEP in a patient who is on anticoagulation? Yes. So both for antiplatelet as well as thrombolytic therapies, for Ascard, for clopidogrel versus for warfarin, right? Yes. So this is a paper which again is a review paper published recently, and it showed that that performing HOLEP on patients who are on anticoagulation therapy is feasible and safe. However, those patients who are on anticoagulation therapy requires longer hospital stay, increased length of catheterization, and increased risk of requiring transfusion. And this is the summary from the same paper in which they have compared the anticoagulant group versus control group. All kind of anticoagulation in the stable: aspirin, dipyridamole, warfarin, and then enoxaparin, clopidogrel. So anticoagulation group in the first study showed less enucleation time, more length of stay, and the similar transfusion rate. Here again you see the more length of stay, more transfusion, and increased length of stay and more transfusion in the patients who are on anticoagulants, but it is safe and feasible. The urinary incontinence rates between HOLEP and TURP are same, and the randomized control trial by Montorsi have shown that 44% rate of urge incontinence following the HOLEP. But after 1 month, majority of patients have resolved. They are free from urge incontinence. Again, Kuntz et al. Have shown that 2/3 of men with preoperative urge urinary incontinence, they experience resolution of symptoms by 12 weeks in the postoperative period, while Jilling et al. Have shown that there is similar incontinence score between TURP and HOLEP. And the stress urinary incontinence in these randomized control trials, in all these 3 randomized control trials, was around 1%. So again, this is a paper which was published in 2016 by Kobayashi from Japan, International Journal of Urology. And they tried to find out the predictive risk factors of postoperative urinary incontinence following holmium laser enucleation of prostate. So they reviewed predictors of postoperative urge incontinence, including 203 patients. And they found that the overall rate of urinary, so not urge incontinence, urinary incontinence was 24%, out of which 55% experienced stress urinary incontinence, 29% urge urinary incontinence, and 16% experienced mixed urinary incontinence. On the multivariate analysis, they found that those patients in whom the operative time was longer, more than 100 minutes, those who have more blood loss, more than a drop of more than 2.5 grams of hemoglobin, they were associated, they had more development of postoperative urinary incontinence as compared to the ones who have less enucleation time and who have a small volume resection. Now the learning curve. So there are several reports which have shown that the learning curve for HOLEP is very much steep, and these papers have analyzed the completeness of procedure or technical success in terms of complete enucleation, complete morcellation without technical failure, in terms of operative time, safety and complication and conversion of the procedure to TUR or open prostatectomy, as well as the functional outcomes. And these studies have shown that in order to master this procedure, you need between 20 to 50 cases. So this is one of the last slides, and this is describing about the different treatment modalities for BPH, the monopolar TUR, bipolar TUR, photovaporization of prostate, and HOLEP. So the level of 1 evidence exists for all of these modalities. The long-term data is available for monopolar TUR as well as for the HOLEP. More than 5-year mature data is available. So there is no limit for prostate size resection. The duration of stay is less compared to monopolar TUR. And the pathological material is available in HOLEP. It's not available in photovaporization. The TUR syndrome risk is virtually negligible. And the delayed complication rate includes bladder neck contracture, which is similar to the monopolar and bipolar TUR. Urethral stricture rate is less as compared to monopolar TUR. So to summarize, HOLEP has the advantage that it is performed safely, and in select cases you can do it as a daycare procedure. It has a good hemostatic modality, so those patients who are on anticoagulation, it can be used safely. The normal saline is being used as an irrigation modality, so there is low risk of TUR syndrome. There is no limit for prostate size. It shows decrease. It shows advantage in terms of less catheterization time, less blood loss, and less hospital stay. And it has comparable results with respect to standard TUR and open prostatectomy. The disadvantages are initial cost, steep learning curve, and some of the tissue is lost because of thermal artifact, and it requires increased time for the resection. Thank you very much. Any queries? So what's the take-home message for HOLEP? So do we all agree that it will be a new gold standard treatment for BPH? Yes or no? Why? Just summarize it. More safer?
For all sizes of, regardless of process size.
Very nice.
And it's a daycare.
It can be daycare. It's not a daycare. In selected cases, you can have a daycare procedure, right?
Retrograde ejaculation.
The retrograde ejaculation is more or less the same, but sexual side effect profile is slightly better. The efficacy in terms of objective. So I think we move on to the next part, which is about the technical aspect of HOLEP, and Professor Ahmad is going to talk about the techniques for bilobar and trilobar HOLEP.
Okay, I mean, from the talk, it seems that that's the best thing to do. Anyone is doing it? Is anybody doing HOLEP? Anybody has seen it being done? Videos only? Okay. Now, what are the problems with HOLEP? Anyone can tell me what are the problems with HOLEP? There must be problems. Otherwise, it could have been taken up by all of us.
The first thing is you need laser.
So you need to have, obviously, you need to have a separate resectoscope. You can't use it with the regular resectoscope. So it is difficult to learn compared to TUR. So one of the major difficult dissection when you're close to the sphincter, particularly because we know that the sphincter is predominantly anteriorly, right? So anteriorly, you have to be extremely careful, and there is very little window of opportunity in that area. So cut down the power to 45 and cut away from the sphincter, not towards the sphincter. So you're moving the adenoma back into the bladder and cutting away from the sphincter. So this is the mucosal strip which is left. And this is identification of this mucosal strip is extremely important, because if you go further to that, you will be very close to the sphincter. Again, here in the anterior area, you have to use laser fiber. You need precise cutting. Again, sphincter here. And it is the stretching and pulling on that sphincter with the resectoscope that can cause neuropraxia and little damage to the sphincter with temporary incontinence. So this is something that you need to be very careful about. Last vestiges of the adenoma, and here it flops into the bladder. Okay, there it goes into the bladder. So this is one of the lobe done. Same exercise again on the other side, giving a midline incision, giving us 5 o'clock incision, deepening that incision, moving, defining that groove between the sphincter and the adenoma. So that is once defined. Particularly, it becomes very difficult when you are at about 2 o'clock to 12 o'clock position. That's the area which is a little difficult. So be very, very careful and do it under clear vision, because close to the verumontanum, it's very easy. Just lateral to the verumontanum, you can define that groove and develop that plane between the adenoma and the prostatic capsule. But once you are up there, it is really difficult to know where the sphincter is. But this is helped by staying within that groove of sphincter. Again, blunt movement, pushing the whole adenoma with your resectoscope and cutting those things which are just like doing an open surgery, a combination of blunt and cutting, in which you push some tissues, you do define plane. When you're pushing it, you're actually defining that plane automatically. It would not move through the body of the adenoma. You cannot go through the body of the adenoma. You will only go through that plane which gives way. And the plane which gives way is the adenoma and the capsule.
Sir, if a very large medial lobe indenting into the bladder, it is possible to cut it and...
So if you have a large median lobe, you will do the 3-lobe resection. And I'll show you the 3-lobe resection scheme in which you do the median lobe first. Because median lobe, once out of the way, then you would do a 2-lobar resection, as we have shown.
Very large, it is covering both the
The advantage is now when you're doing a TURP, you have TURP in your mind, you have to cut like this. So you actually don't see the bladder, you don't see the end of the adenoma of the median lobe, right? Here, you divide right in front, a transverse incision right in front of the verumontanum, and then keep lifting it up. And just when you're lifting it up, you just need to stay in the right plane. If you're in the right plane, you keep lifting it up, you would know when the bladder neck comes, and then you need to incise. Cut, and it will flop through. So this is the other lobe, and it's almost done here. You see, I mean, being in the right plane, there is very little bleeding. And that's why with all kind of anticoagulants, clopidogrel, the data is still patchy and people are really a bit afraid about using clopidogrel. But warfarin and all other things you can safely do. Patient probably need to stay in the hospital for a little longer. So once both these adenomas are dropped into the bladder, you have a nice little fossa. The next step is extremely important. Once this adenoma has gone into the bladder, you need to do hemostasis as well as possible, as good as possible. You need to have an absolutely dry fossa before you start moscillation. That's the most difficult part of surgery. It is the easiest part as well as the difficult part. Moscillation can be disastrous because when you're using a moscillator, it has got cutting blades in front, and if you have sucked the mucosa of the bladder into your moscillator, it can cut a nice little hole in the bladder and you can see small bowel. So you don't want to see that through the bladder, right? It's not a desirable thing to do. So requirement before moscillation is, number one, that you should have an absolutely dry field, your vision should be clear, and there should not be any bleeding. So you do hemostasis. And the second important thing is that somebody needs to be standing on your irrigation. Nobody can sit at the back and enjoy music while the moscillation is going on. People have to stay, both bottles should be running simultaneously of your glycine or normal saline, you don't really need to do glycine. And it should be running simultaneously. Prolapses, you would suck the mucosa of the bladder into your moscillator and you cut energy spread. Defocused laser energy means that you do not pinpoint the laser, you be in that area and keep moving and spraying the laser energy in that area, and with your pedal halfway. And this way, you would be blenching those vessels, you will be coagulating the capillaries rather than cutting. Otherwise, you can cut into the vessel. You can cut a vessel and it will start bleeding again, right? So this is a little difference in the technique. This is your moscillator. This is the one that we use. And this moscillator, the important thing is that you have to change the resectoscope now. You can't use the same resectoscope for moscillation. Moscillator is a different scope. And this scope, the exchange has to be very quick. So you come out, you see, when you're doing alic evacuation and you evacuate the bladder, once you go again into the prostatic fossa, you find that there is again a lot of hemostasis or bleeding. Because prior to going into an alic evacuating the chips, you had a dry field, you go in and you come back and you find that there is significant bleeding. And this is exactly what happens. If there is any delay before removal of your laser resectoscope and introduction of a moscillator, then they would feel bloody again, and then it's a disaster. So out and in. So you should be ready. Ask your technician that is the moscillator resectoscope all ready, and once it is, then you remove the resectoscope and introduce your moscillator. Now moscillation, you've got a pedal, and this pedal has suction as well as cutting. So if you press it half, it will be sucking. And suction is done to attract the cotton ball lying in the bladder. So once you start, see, this is, all these are lying in the bladder. When you half press your pedal, it will attract that ball to come on tip of the moscillator. Once the connection is made, then you can press it full and it will start, the blades will start churning. And once the blades start churning, these moscillator will cut these cotton balls into small bits and pieces. Make sure that there is bladder wall above, bladder wall below, and on sides, and the bladder is full. You can also ask your assistant to keep a hand on the hypogastrium to make sure that the bladder is full throughout during your moscillation process. Stop cutting. Is that clear? So three important things. Number one, very nice hemostasis, quick exchange of resectoscope for a moscillator, and third thing is that continuous two bags running simultaneously, and somebody making sure, at least in the initial part of the surgery, that the bladder is full all the time when you're doing moscillation. Now, sometimes you cut these things into really small, medium-sized pieces, and these medium pieces can neither be moscillated and nor they will come out through the alex. So what you do is use a little special loop to attract these, like you use your loop to take out some of the chips in the end, which are difficult to evacuate. So this is the mosylation process. Go close to the adenoma, engage, and start cutting. And those
need to touch the tissue.
you need to press it half, and the tissue will come to you, because this will activate the suction process. Once it started suctioning, it will suck the irrigation as well as the adenoma. And adenoma comes and gets stuck to the tip of the mosulator. Once it is very close to the mosulator, you can press it full and it will start churning. Because when you press it half, no knife will be activated. You will only be activating the suction process.
And sir, what about biopsy? Can we take it from?
Oh, these are nice for biopsy. Yeah, because what you in TURP you use, most of the tissue is touched by a dithermy, because you cut thin pieces, slice of tissues. Now in laser, you see we have used very little energy, and we have used energy only on the peripheries. The whole adenoma is untouched with laser or heat energy. So this is a normal viable tissue. And when you cut it, you are actually cutting it with a cold knife. You're not using hot, because mosulator is not a hot current. It's a cold knife. It's just a rapidly churning. It's just like your blender mixers that you have at home. Okay, नहीं इसके आखिर में जाइए, इसमें ट्राइलोबार रिसेक्शन होगा. Just go to the last 2 or 3 minutes.
A 30-degree lens.
Yes, no. Yeah. So this is the W thing, which can be used for removing the small bits and pieces. So these are difficult to mosylate. They can either be an aleck evacuator, or you can use this to remove. Now, if you don't have a mosulator, you don't want to use in the initial phases a mosulator, what you can do? There are 2 things that can be done.
We can hold and remove all the shapes.
Mushroom technique.
So you can cut a mushroom. Cutting a mushroom means that when you are doing your adenoma, you would cut all around, but just leave a little stalk of tissue on which the adenoma is sitting like this, right? So this is mushroom technique, and this is still attached to the bladder, still attached to the prostatic capsule. You introduce your resectoscope and start cutting. This is a totally devascularized tissue. It's not going to bleed at all. So you can use a resectoscope to do the last bits. The second thing that is also described in literature is that for large adenomas, once you have done, and both these adenomas are there in the bladder, you can make a little incision, a cystostomy incision, and take it out. Something that very few people practice, but if you don't want to, or you don't have a mosulator, you can still do it this way. Okay, now I think this is the trilobar resection. So there is a deep groove. You see, there's a deepish groove between the lateral lobes and the median lobe. And to start off this type of trilobar prostates, you need to define the end of the median lobe and the beginning of the verumontanum. So you give a median to 5 and 7 o'clock incisions, and then you cut transversely right in front of the verumontanum, and keep lifting this tissue up, and this median lobe will again nicely detach from the capsule and will fall into the bladder. Since there is very little adenomatous tissue here, you have to use more of your laser current rather than your blunt dissection. So when you're lifting it up, you can actually define now, all of a sudden, you will see the black hole, and that is the bladder. Once that is reached, you would stop cutting and you will just push it. So this way, you're unlikely to do trigonal injuries. And since your bladder neck is still defined on the 2 ends, you know exactly when this adenoma median lobe is finishing. Okay, we'll stop here, and if there are any questions, otherwise we can move on to the simulator. नाजिम सिमुलेटर को कर लें जब तक बात कर लेते. होल ऐप लगा दो यार. बायलोबार. होल ऐप. हाँ. Oh, sorry, simulator. If there are any questions from the audience not at the AKU, please feel free to ask questions while we are setting up the whole app. Yes.
So would you recommend whole app for a small fibrous prostate?
Well, that's not a typical indication. Unlike TURP, even when you're doing TURP, it is not ideal to start with the small prostates. They're tricky. For whole app, the bigger the better. I mean, not huge prostate over 200 grams, but something like close to hundreds, between 80 to 120 grams are the ideal to start. They're the easiest because the boundaries are very well defined. For prostate, which are small, fibrous, less than 20 grams, kind of obstructing prostate, will probably TUIP would suffice.
Case reports of rectal injury in small prostates.
Well, I mean, I think there must be people. One of a friend of mine who works in Europe told me that he was able to cook the whole bladder, and he didn't realize until the second day after surgery that the whole bladder is fibrosed and it is laser scarred. And it was, in the end, it was only a 20 ml bladder for a normal bladder. So all kind of complications. If you do not understand the anatomy and define the capsule nicely, you can keep digging it deeper and deeper and you can reach anywhere. So I'm not aware of specifically, but it can happen potentially. Like even TURP, people have gone into the rectum. Okay. So which one we want to, let's start with a 80 gram. Okay. Any volunteers? सिखा दो दिए पूरा. आइए. Hafiz, you want to do it? आइए. So कर दो यार. आइए वाला start कर. This is your now the key is that when you're holding your resectoscope, this is the movement that you will be doing, and when you are resecting, so
right? So you don't need to go the whole room.
Position of the laser fiber should remain constant, or can we move the laser fiber as well?
Well, laser fiber, the principle is that you should be seeing the green covering or the blue covering of the laser fiber. And this is for both your flexible ureteroscopy and for this. Because although there is ceramic coating at the end of the resectoscope, but still you can burn your resectoscope. So now if you do like this, go in, and move your hand like this, you will be, if you move it up, you will be able to see the capsule. Because what you are doing is using the resectoscope as your retractor. And when you move like this, you will be parting the median and the lateral lobes, and you will be able to see this groove in the depth. Because what is happening is all this tissue is making that identification of the capsule difficult.
Between the capsule and adenoma, the tissues are not clear. Like
yeah, because if you go into the bladder, right, and now you use this moving up and down, you will be able to see the capsule.
That section is doesn't give us idea.
Yeah, it's because, yeah, I mean, start cutting from here, see the capsule in the bladder neck further.
Unless we don't see the capsular fibers, we should not go laterally. We should keep on going deep.
Yeah, you have to identify one plane and then move to another plane. So if you move from one plane to another without identifying the first plane, you would not know where to go. So identify the capsule first in the groove between the median and the lateral lobes, and then lift it up. See, now this is the capsule here. You can see the circular fibers.
Still I am superficial.
So the cut of a expert resectionist versus the cut of somebody who is learning is like what you have read in jurisprudence, that in order to identify whether it's a murder or it's a suicide, you look at the wound. If the wound is jagged, then it is suicide. So if it's a nice clean cut, it's a murder. So you would know whether you're doing a murder or you're doing a suicide.
I think this one is a capsule now.
Okay, fair enough. So now I think to learn, the difficult part is to do the adenoma apex of the prostate. Now you need to see where you need to go. Now this is very important. ये capsule आ गया ना आपको, ये capsule, ठीक है. So come back. You've gone into the capsule. ठीक है. You don't need to go any further.
This is the capsule now.
Yes. Yeah, that's fine. Now keep coming back. Now you need to cut like this along, and to do this, you need to not only cut but push. By pushing, you will be able to expose the space between the adenoma.
This one is the
Yes. Now, while you are cutting, you keep moving it like this and putting your scope between the adenoma and the capsule so that you are able to expose the adenoma, the capsule.
It's just like open surgery, like traction. And then
yeah. So somebody is providing traction, they're actually describing the anatomical planes. And then it's easy for you to go into that plane. Do a combination of blunt and so you see, come back a little bit, come back. देखिए ये ग्रूव है स्फिंक्टर की, ये आप देख रहे हैं, ये distal part of the verumontanum is finishing here. This is distal verumontanum, and this is the groove of the sphincter. Now, if you make a millimeter a mistake here, then you're cutting onto the sphincter. So you need to keep into this plane, keep lifting it up, and keep moving laterally. This is the most difficult part, and here you've gone deeper. You see? This is what Dr. Nazim was asking.
Sometimes we see that apex of the prostate
is hanging over.
Is hanging beyond the.
But the sphincter is still beyond the distal to the end of the prostate.
We should look for the.
So once you have made that turn, that hockey stick is completed, then you push it medially and cut it. So you are moving away from the sphincter, moving the adenoma away from the sphincter. So anyone else is interested? Are you?
लोग निकाल के मुझसे लेटर कर लेना.
So now try without using your, see, a little bit of an extra current has been used in the apex. What you needed to do is to use this to push the adenoma up and use your blunt rotating movements like this to push the adenoma away from the capsule. Yeah. So if you put your hand on the top here, like this, it will be easier. Be very careful when you resect a new slither of mucosa that you are still in the right plane. So there is no harm in coming back, looking at that mucosal groove of the sphincter and the limits of the adenoma.
Easy. पीछे बैठ के easy लगता है.
पीछे बैठ के easy लग रहा था. So इसमें आपके नेगेटिव आ जाएंगे, ये जो ग्रीन ग्रीन नजर आ रहा है ना, this is extra heat energy used.
Right.
So एक मिनट मुझे दिखाइए, मैं आपको बताता हूँ कि blunt movement को कैसे आप यूज करते हैं. And then you can do it. I'll just take it for a second. So you are in that plane. Now what you need to do is to use movements to identify. And I think what has happened is, okay, so this has to go. And this, and this, and this, And whenever you find little resistance, you can use the cutting energy, but by and large, try and move it. Now there's some restriction here in the movement, but in patient, you can easily move this adenoma. So, जी स्फिंक्टर आ गया, वहां पे लिखा हुआ नहीं आएगा. ये देखिए, ये ग्रूव है स्फिंक्टर की, and I've touched that sphincter. See? ये ले. So ये मूवमेंट से ये पूरा इसमें नहीं हो रहा क्योंकि इसमें थोड़ी सी रिस्ट्रिक्शन है मूवमेंट की, but that sweeping with the resectoscope.
What about the resectoscope which having the beaks, which gives some help to pushing that there's a resectoscope which having the two beaks.
The TURP scope in the laser. I'm not.
Real scenario. You also have the touch feeling, the tactile.
Yeah, you can.
It's just a visual perception. Like this?
Yeah, this is a sphincter, and you need to push it medially. Now, whenever you are in a difficult situation or you don't know where you are going, you move from one place to another. So you go in and do it a little more proximally. So, I mean, in the meantime, when you are still learning, or you still don't have that equipment available, you can use either your Collins knife or you can use your resectoscope to start cutting the apex of the prostate in this fashion and learn how to do it in the real life. And I find it very, very helpful that you get that feeling of cutting in the reverse fashion. Okay, and do it part of the procedure and then do your resection. It's also helpful when you do it like this. You will have a little bit. The problem with resectoscope is when you're cutting like this in a small space, you develop a lot of air bubbles which obstruct your view. So it becomes technically a little difficult. But
those prostates which are so large, the lateral flow, they are protruding well beyond the view. How would you handle that?
So that was I was explaining to Atif that once you have cut your bladder neck, the most critical step is to complete your hockey stick. So if you have cut your hockey stick in the right direction, in the right plane, then you are okay. Because once you've cut and made this turn, then you would use your resectoscope to lift the adenoma up and lateral and start cutting. And then you are away from the sphincter. Because the sphincter is here and the adenoma is moving medially towards the bladder or laterally or up. So, and this cut is very easy because you come to the verumontanum and you have to take a right turn or a left turn. And hockey stick completed. Once you into that, you have made that space, then this space can be developed further by lifting adenoma up and then cutting. So I mean, this is cutting of the apex is slightly tricky, but this is the real art of doing this procedure.
We cut the apex also before we start moving the.
Some people do that, but that's not really required because when you start cutting and you have gone all the way up towards the 12 o'clock position, and you have to then move the whole adenoma from all directions up to 12 o'clock. So it is only adhered with the anterior commissure. So that's the point you cut, and then you move medially, laterally, sorry. So if you keep moving like this, you would never know when you have crossed the midline. So, because you are into that plane and you don't see that groove between the two lateral lobes. So once you have done enough anteriorly and you think that there's very little tissue left because adenoma is mostly hanging, that's the point you come back, incise at the 12 o'clock position and then develop that 12 o'clock position to meet where you have cut up laterally. So then you meet and adenoma will flop into the bladder. Okay, any further questions, queries? Okay, we can wrap it up. Any questions from the audience outside, if there is still some audience outside? So all of you feel it is doable cases and then start doing it? How many of you do complete TURPs? Okay, so this is start doing until you get into laser, start doing your TURPs, part of it at least, in the reverse fashion. And you will get the feeling. Once you get that feeling, then it's probably easier. Okay, I don't think there are any further questions. So really, thank you very much for being attentive audience and still awake, most of you at least, and not busy on your phones, texting, or updating your Facebook status that I have attended the course. Okay. So hopefully we'll have many more like this, and you can even attend it in the luxury of your room. You see the children were coming in and sitting in the bedroom and enjoying the little seminar or webinar. So, and we'll thank you to the sponsors, GETS, for making it possible. Okay, Abdul Hafiz Qureshi, sir, please take your certificates. Anisul Islam. Later, where? Babar. Raja Rizwan. Abdullah Mahar. Abdullah. Mahmood Ahmed.
He's not here.
He has not attended.
He has attended
more than 50%, 51% then. Hassan Siddiqui. Moin Ahmed. Saeed Ahmed. Abdul Mujib. Fahim Ahmed. Fahim Ahmed. Yasir Khan. Hira Bombia. You're very dedicated attendance in meetings. You're from Ziauddin, right? Mohammad Owais. Enjoyed the course? You have a compulsion to say this. Waqas Ahmed. Waqas. Okay. Mohammad Ali. Veda Malik. Zubda Malik, I'm sorry. Zubda, Vitrine, are you? Confidence is the most important. Rajkumar. Naranjan Lal,
Yes, right.
you from the same?
Currently I'm not at Larry.
Yeah, you was at the
Yeah,
same.
yeah, he was in a state.
I was.
That's why you were there.
Yeah.
You were in the same. Rehan Nasir. Salman Jameel. There are hard working banda is pura tha. Mohibullah. Kaleem Khan. Huh? Kaleem Khan bhi 51%. Sana Hussain. समझ में आया तुम्हारी?
Yes, sir.
Was it fun?
51%.
कल अगर आपको देर से किसको करेंगे? Mohammed Shoaib. Okay, thank you very much.
We are left. Sir, where are the
अरे इन बच्चों को तो मिला नहीं. लाइए. लाइए बैंक सर्टिफिकेट दीजिए. क्या नाम है बेटा आपका?
Marvi.
कोई ब्लैंक नहीं है आपके पास?
The blank.
ब्लैंक ले हैं दो. मारवी और मेहताब.
बना हुआ सर्टिफिकेट वो दो आ गए डबल हो गए
अच्छा.
बना वाला और दोनों पेस्ट हो गए
ये आपका नाम है? मारवी का भी फ्रेश आपके लिए बिल्कुल ताजा. डायरेक्टली कमिंग फ्रॉम दादा.
Thank you, sir.
आपका
Excuse me, there is a tea arrangement at the ground floor followed by a group program. So you all are requested to be together at the
हुआ बहुत बुरा है तो उसकी जो है ना लीक हुई है ना उसके बाद हमने उसको डाइवर्जन दे दिया इलियोस्टोमी भी है इधर बनाया इलियोस्टोमी भी है
That's the. अच्छा आपको लिखा हुआ ऑलरेडी था.
नहीं अभी.
Thank you. Tea downstairs.
दो बंदों ने किया बस और
अपना यही है
ना सही